Welcome to the examination case demonstration. We want to use some simulators to demonstrate different examinations you can find in the exam. So, thank you. Lie down. We start with general examination. Before you examine any patient, you greet the patient, you introduce yourself, and you take permission to examine. Good day, sir. I'm Dr. Ernest. I want to examine you. Thank you. Lie down. The position for general examination is the patient lying supine in anatomic position with the palms facing upward. Patient lying supine, the legs about together. Is that clear? Now, the exposure, the patient will remove his shirt like you can see, so that you have access to the whole of the trunk. Is it clear? Is it clear? Yes. Okay. Now, what are the steps? We follow inspection, palpation, percussion, and auscultation. But for general examination, there is no percussion or auscultation. We only have inspection and palpation. What is the inspection part of general examination? As the candidate, you come to the right-hand side of the patient. Even if the right-hand side of the patient is attached to the wall, you excuse the examiner to enter to the right-hand side. Is it clear? Because if you examine a patient from the left-hand side, you may be vetoed completely. Is that clear? So on the right-hand side, general examination, how do we inspect? You inspect the patient from the head down to the toes. You look at the hair, you look at the face, you look at the whole of the body down to the toes. You take note of one, the average age group the patient fits into. We normally use young, middle age, and elderly. If you think the patient is less than 40, you say the patient is young. If you think the patient is between 40 and 60, you say the patient is middle age. If you think it's above 60, you say the patient is elderly. Is it clear? Now, the second thing, you make an assessment of the health status of the patient, whether he is ill-looking or is not ill-looking. And if he is ill-looking, you establish whether he is chronically ill-looking or he is acutely ill-looking. If you are not sure where he fits into, you just say he is ill-looking. In the exam, never say something you cannot defend. Never say something you are not sure about. If you even look at the patient and he doesn't look ill, just say the patient is calm and cooperative. Some examiners don't like you to say the patient is well looking. The assumption is that anybody who is in the hospital has some problem. Is it not so? So they don't like to hear that. So you just say the patient is calm and cooperative. If you observe the patient is in distress, you say, when you are making an assessment of the health status, the patient can be in respiratory distress. The patient can be in pain distress. Or a patient may not be in distress and you just say it's not in any distress. Is it clear? Then next, you observe the nutritional status, especially if the patient is wasted. You say it. But if the patient look normal, you may not bother to say anything about the build or the stature. Is it clear? But if he's wasted or he's obese, you say it. Then lastly, any other thing you see on the patient, like if there is a cannula, if there is a line, if there is a catheter, if there is a drain, there is a chest tube, anything you see attached to the patient, you report on your inspection. Is it clear? Is it clear? That is the inspection part of general examination. If you are doing an exam where they expect you to present, like the dentist, you will do short case. Are you listening to me? Are you listening to me? When you are presenting, you follow the order. You don't present what you did in palpation before what you did in inspection. So what you did in inspection, you will present first. Is inspection clear to everybody now? Now palpation. How do we go about palpation? We also walk from the head down to the toes. Are you with me? So I will begin to describe the things we do. You start from the hair, you check for fluffiness. In the hair, can you pick it? What I'm doing, you center on it. In the hair, you check for what? Fluffiness. After that, you come to the eyes. First of all, the dorsum of your hand, you place on the cheek. You wait some seconds to check for temperature. Are you with me? Are you with me? You check for temperature. Then your tongue, you place on the lower eyelid and you lower it down. And then you look at the conjunctiva to assess for conjunctiva pallor. Is that clear? Then next, your thumb and index finger over the upper eyelid. You pull up the upper eyelid. Bring your other index finger in front of the patient. Ask the patient to focus on it. Focus on my finger. Now follow my finger. Follow it. As the patient is following it, you look at the sclera to assess for jaundice. Please, you don't move your finger side to side or up and down. You are not checking for extraocular movement. You are checking for jaundice. So that one motion from midline downward is sufficient. Is that clear? The next thing, you come to the mouth. You ask the patient, open your mouth, bring out your tongue, raise it up. As the patient is doing that, you observe for buccal mucosa pallor. You observe for central cyanosis. And you observe for the level of hydration. You look at the tongue, the color of the tongue, the color of the buccal mucosa to assess for buccal mucosa pallor. You look at the lips and the tip of the tongue. If it is bluish, it tells you the patient has central cyanosis. You look at the tongue. If it's wet with saliva, the patient is well hydrated. But if it is dry, the patient is what? Dehydrated. The buccal mucosa is the best place to assess for pallor because it can hardly be masked. The conjunctiva can be masked by tearing. Do you understand? If a person cries, it makes the conjunctiva become red, and that can deceive you and give you a false positive that the patient is not pain when he's pain. If a patient takes something that colors the tongue also can give you a false report. Some people's palm are naturally very white, thick, and you can't appreciate it. And some people's palm can become colored with something too. but it's difficult for something to color the buccal mucosa. It's the best place to assess for pallor. Now we continue our examination. Don't forget what we have done in palpation. We check we check fluffiness of the air. We check for temperature. We check the eyes for conjunctival pallor. We check for jaundice, and we check the mouth for buccal mucosa pallor, for central cyanosis, and the level of hydration. The next place you come to is the neck. In the neck, we palpate for the lymph nodes in general examination. You go systematically. You start from the submental. You dig your fingers, the pop of your fingers, the pop. You dig it into the submental area. The both fingers. You know, you don't put one. Do you understand? The both. You dig it in and you rub against the bone to see if you can feel enlarged lymph nodes. Then you go to the submandibular. You dig in, rub the pulp against that bone. Then pre-auricular, you rub against the bone there. Then post-auricular, you ask the patient, raise your head, you check occipita. Is it clear? Then you now come to cervical. You check the upper group of cervical, the middle group of cervical, the lower group of cervical, and then you come to supraclavicular. You dig your fingers into the supraclavicular region. You try to rub against the clavicular bone and see whether there are enlarged lymph nodes. Is it clear? You can do all that with the patient lying down. But another system some people do is to ask the patient to sit up. It's also accepted. Is it clear? But this is the style I like, and that's what I'll teach you. Shall we move on? Then after that, you come to the axilla. In the axilla, we also palpate for lymph nodes. To examine the right axilla, you take the patient's right hand, you shake with your own right hand. You abduct the hand to expose the axilla. And then you lay the patient's upper limb on your forearm. Now you have access to the axilla. You palpate systematically. You start from the medial wall of the axilla. You rub that place against the bone to see if there are palpable lymph nodes. Then you come to the anterior wall, which is this fold of muscles extending from the chest to the humerus. Are you following? So you go beneath them and try to rub against that place to see if there are palpable lymph nodes. Then you come to the lateral, which is against the humerus. You rub against it. You feel to see if you can palpate any enlarged lymph node. Then lastly, not lastly, you now also go to the posterior wall. Are you with me? The posterior wall is also formed by folds of muscles, latissimus dorsi, that is extending to the humerus. So you palpate that place against it to see if there are enlarged lymph nodes. Then the central area is the central region of the axilla. You feel it to see if there are lymph nodes enlarged in the central group. Then you now poke your finger in to get to the apex, the apical group, and you feel to see if there are lymph nodes. After doing the right, to do the left, you shake the patient with your left hand, you abduct and place the patient's limb against yours. Then you have access to the axilla. So you check first the medial, the anterior, the posterior, the lateral, the central, and apical. Is it clear? After that, you come to the the epitrochlear group. You hold the hand like this, about the wrist. You raise it up and you use the pump of your fingers to feel around your olecranon and the trochlear bone to see if there are enlarged lymph nodes there. You also do for the other hand. Then after that, you now come to the hand. Remember, I said we are working from the head downward. For the hands, you place both patients' hands like this. You put your hand in between. First thing, you assess for palmar pallor. Assuming that you are okay, you compare the patient's palm with yours. You should be seen comparing both. Is it clear? Is it clear? You should be seen comparing both. After that, you turn the fingers and look at the dorsal aspect of the fingers. You look at the nail bed and observe for peripheral cyanosis. If there is peripheral cyanosis, you see some blueness in the nail bed. Then after that, you check for capillary refill by applying pressure on a nail. It will blanch. Immediately you remove your hand, it should become red again within seconds. Is it clear? That's how you check for capillary refill. The last thing you do with the hand, you squat and you look at eye level to assess for finger clubbing. Most patients in surgery will not have finger clubbing, but if you do find, like they teach you in medicine, you can begin to grade, but most patients will not have. After the hand, you now come to the axilla. Because of the kind of patient we are using, we cannot, sorry, I said axilla, the groin. You come to the groin. For the groin, we assess for inguinal group of lymph nodes. The place to check for them is at the medial aspect of the thigh, just below the inguinal ligament, around the femoral triangle. Do you understand? You palpate both at the same time, somewhere around here. Do you understand? So you feel for both at the same time. Then after that, you come to the popliteal group of lymph nodes. You do one at a time. To check for one, you flex the knee. Dig your fingers into the popliteal space and feel for the lymph nodes. Then you do the other, you flex the knee, you dig your finger in and feel for popliteal group of lymph nodes. Then after that, you come to the feet. In the feet, you check for pedal edema. To do it, you use your tongue. You use your tongue. You cannot use your index finger. You won't get any mark. You apply your thumb on the bony prominence over the mid part of the feet. Are you following? You look at the patient to be sure you are not causing him pain. After applying pressure for some seconds, you look at it to see if there is any depression, or you feel to see if there is any depression. If there is no depression, that means there is no edema at that level. But you don't stop at that. You come to the malleoli. Using your thumb and index finger, you palpate the malleoli. Look at the patient and apply some pressure. After some seconds, you observe. If you don't see anything, you feel. If you can't find edema at this level, there is no need to continue. Is that clear? But if you find edema here, you will now continue. You continue along the anteromedial border, where I'm touching now, anteromedial border of the leg, at the same level. You continue to check while looking at the patient. You rub to see, you check, you do like that. You continue till wherever the edema subsides. Is that clear? Then after that, you ask the patient to sit up. When the patient sit up, you come to the prominence of the sacral bone. You palpate and look and see whether there is sacral edema. After that, general examination is complete. You tell the patient, thank you. Is that clear? Observe there. Now we take abdominal examination. The position is supine with the palms facing up like we said before. The exposure is from the nipple to the mid-thigh. But most time we don't do that to preserve some dignity for our patient. But in the exam, you must take that permission from the examiner. If you don't, they will assume you don't know the position, the exposure, and you will lose the mark for exposure. Is it clear? You must tell the examiner, please sir, I would like to expose my patient from the nipple to the mid-thigh. Most times they will say don't bother, and they will give you the mark. Is it clear? But then you should still expose the groin. If you don't, a patient may have a hernia and you may not know. You know what I mean by the groin? That area above the genitalia. It's only from the genitalia you cover. Do you understand? But for the kind of patient we have, we won't do that. Is it clear? So we carry on. To do abdominal examination, you must be on the right side of the patient. You are going to follow the routine abdominal examination requires you to examine the anterior abdominal wall and to do a rectal examination. Is that clear? Routine abdominal examination is what? Anterior abdominal wall and rectal examination. Please don't forget that. Rectal examination is part of routine abdominal examination. Now for the anterior abdominal wall, we follow inspection, palpation, percussion, and auscultation. For inspection, there are 4 steps to follow. The first step, while standing on the right hand side, you just inspect the entire abdominal wall. You note anything you can see, like a swelling, like a surgical scar, like scarification marks, like distended neck veins, like nodules. Anything you see at all, you report. That first step, when you stand by the side to look, you must also look over to look on the left side. Are you following? If you can't see it well, you must look over and see, because sometimes there may be a lesion hidden there. So first step of inspection, you stand by the side, you just look over the entire abdominal wall. Second step, you squat by the side, right side of the patient, and look at eye level. You observe for movement with respiration, and you observe the contour, whether it is distended, it is full, it is flat, or it is scaphoid. The third step, you go to the foot of the bed. You squat at the foot of the bed and you observe for symmetry. The fourth step of inspection, you ask the patient, turn to the other side, cough. While the patient coughs, you observe for hernia. How do you know hernia? There will be visible expansile cough impulse. So when the patient is coughing, you focus on those areas where hernias can be. In the epigastric region, around the umbilicus, in the groin, and then in the lower midline, the spigelian hernia, just lateral to the rectus muscle before it enters the pubic bone. Are you following? You have spigelian hernia here. So while the patient is coughing, you observe if there is any such expansile coughing pulse. After that, inspection is completed. You go to palpation. There are 3 steps in palpation. 1, light palpation. 2, deep palpation. 3, organ palpation. Now, light palpation is meant to assess for tenderness. So before you go about light palpation, it is expected that you ask the patient, is there any area where you are feeling pain? That question carries a mark in the OSCE and also in the short case. So never forget that. As part of light palpation, you first of all ask, is there any area you feel pain? Show me with 1 finger. The reason is this. When the patient shows you where he's feeling pain, you are expected to start your light palpation far away from that point and you end there. So if you choose to start at that point, you also score negative mark. Is that clear? Now, before we go ahead in palpation, you must know the 9 regions of the abdomen, because those 9 regions are the areas you will palpate. If you come in the exam and you are just rubbing your hand around the whole abdomen, you are a native doctor and you will be given a native doctor's mark. Is it clear? You are supposed to systematically palpate each of those 9 regions. So what are these 9 regions? They are defined by 2 imaginary vertical lines and 2 imaginary horizontal lines. I start with the horizontal lines. The upper one runs through the subcostal plane. It's called the subcostal line. You feel the lowermost border of the subcostal margin. There you have the tip of the 9th rib. That is where you trace that line. Some people say transpyloric. Some examiners don't accept. Why? Because you can't see somebody's pylorus, but you can feel somebody's 9th rib. So you can use that as an anatomic line to take the subcostal line. The lower horizontal line, you feel for the iliac crest on the both sides, and then you take a line along the iliac crest. Is it clear? The vertical, so that line is called transiliac line. The vertical lines, you feel the borders of the clavicle, you locate the mid portion, you take a line from the mid clavicular line, you take it down to the mid inguinal line on both sides. On the left, the same thing, mid clavicular to mid inguinal. So when you draw those imaginary lines, it will define 9 regions, namely right hypochondriac, right lumbar, right iliac fossa, hypogastric or suprapubic, umbilical, epigastric, left hypochondriac, left lumbar, and left iliac fossa. So when you are palpating, you are supposed to touch those 9 regions. Examiner is looking at you. The way the marking scheme is done in the OSCE, it's not whether you do something, you just get the mark. It is graded. If you do the proper thing, you get the full mark. If you do what is partially correct, you get the partial mark. Are you following? If you did not do at all, you get 0. There are some things you will do, you get a negative mark. Don't tell me it is better not to do at all. It is better you practice and you do the proper thing and get your marks. Shall we move on? So we now go to palpation. Like I said, it starts with what? Light palpation. You first ask the patient, sir, is there any place you feel pain? Please show me with one finger. Okay, he feels pain here. So you come, you start your palpation far away from there. Light palpation, you just touch the abdomen and look at the face of the patient to see whether there is any sign of pain. When you want to palpate, your whole hand will be flat on the anterior abdominal wall. You can adjust it anyhow, but you use the palmar surface of your fingers to palpate. Is that clear? The palmar surface of your fingers. Your other hand should not be by your side, should not be in your pocket, should not be in your back. You place it on the bed or on the patient or on your palpating hand. I like to place mine on the bed. So if I want to palpate, since the patient has pain here, I will start from the right hypochondriac region. Do you see my palms are flat on the abdomen? I am not poking. My hands are not entering at an angle. Do you appreciate? It's flat. I make it flat. So I'm in the right hypochondriac region. While there, I look at the face of the patient. Light palpation means you just touch. That is all. You don't do this in light palpation. You just touch. You come to the lumbar region, you touch. While looking at the patient, you touch in the iliac fossa, you touch in the epigastrum, you touch in the umbilical, you touch in the right hypochondriac. I can come here now, is it not so? To touch in the suprapubic, and then I touch in the lumbar here, and lastly I will touch the left iliac fossa. So what I want you to notice is that light palpation, you are just what? Touching. You touch. Palpation, you go to deep palpation. Deep palpation is meant to assess for masses. If a patient has tenderness, you will still give attention to it. So when you want to start your deep palpation, you start what? Far away from where the patient has tenderness. And when you are doing it, you will now be more careful because you know the patient has what? Tenderness. So how do we do deep palpation? The same way you come, your hands flat. The difference now is that you apply some pressure so that your hands are digging into the abdominal cavity. Then you begin to make circular motions, trying to feel for masses. Is it clear? That's what you do in all the 9 regions. You do that in all the 9 regions. Then when you get to where there is tenderness, you be very careful. Is it clear? So once more I differentiate. Light palpation, you just touch. You just touch. Deep palpation, you apply pressure and you make circular motions. You apply pressure and you make what? Circular motions to feel for masses. If you locate a mass, are you with me? You will suspend abdominal examination. You will examine that mass before you continue abdominal examination. Is that clear? As you will examine an abdominal mass, you come to where you located the mass. Let's assume we located the mass here. First, you touch a normal part of the body, you touch the mass, you touch the other part of the body. to assess for what? Differential warmth. Already you have checked for tenderness around the abdomen before, but you can still do it again. You touch the mass and look at the patient to see whether there is tenderness. Then the next thing, you feel around the mass to see if you can get around the mass. Is it clear? If you can get around the mass. If you can get around it, you measure in two planes, horizontal and vertical. If you cannot get around it, the much you can palpate, you also measure horizontal and what? Vertical, 2 dimensions, or vertical, horizontal. Then after that, you now palpate the mass to check for the consistency. To check for the surface, you just rub superficially like this. To check for the consistency, you dig the top of your fingers into the mass. Is that clear? Then the next thing, you confirm whether this mass is inside the abdominal cavity or is within the anterior abdominal wall. To do that, you ask the patient to place the hands on the chest, and you ask the patient to raise both legs up at the same time. Raise both legs up. No, you raise both legs straight up. Okay? Now, when the patient does this, if the mass is in the abdominal cavity, it will become less visible. If it's inside the abdominal cavity, it will become less visible. Why? Because the anterior abdominal wall muscle will contract and push it far inside. But if it is within the anterior abdominal wall muscle, it becomes more visible. Because as the anterior abdominal wall muscle contracts, it makes the mass more prominent. Is that clear? Okay. So, but if you did not find any mass on deep palpation, you go straight to what? You go straight to what? To organ palpation. Now, how do we do organ palpation? We focus on 3 organs. We focus on what? 3 organs. We focus on what? 3 organs. They will not be gentle. We focus on 3 organs. The 3 organs are the liver, the spleen, and the kidneys. Those are the organs we routinely examine in routine abdominal examination. The only time you check for any other organ is when they give you a case scenario. Do you understand what I mean? Like they say a patient has obstructive jaundice. You will not deliberately look for the gallbladder. Or a patient that has difficulty with passing urine, you will palpate for the bladder to see whether it's distended. Or a patient that has a gastric outlet obstruction, you will palpate for the stomach and you will check for succussion splash. Do you understand? So we will show all those ones, but first of all, let's do the routine thing. Are you with me? Now, the routine palpation for organ, we start with the liver. We start with what? The liver. If you check for spleen before the liver, you will lose mark because you are not orderly. Examination has a sequence. You are supposed to always follow the sequence. Is that clear? So you check for the liver first. How do we examine for the liver? You use the radial border of your index finger. You place your hand like this in the right iliac fossa. You ask the patient to breathe in and out. When the patient breathes in, you dig your finger in. As he's breathing out, you wait to see if the radial border of your index finger can feel the enlarged liver. Is that clear? So after that, when it breathes in again, you go in. You keep going in until you feel the liver or you get to the right costal margin. If you get to the right costal margin and you cannot feel the liver, it means the liver is not enlarged. But if you do feel the liver, for example, like in this place, you must characterize it. If you feel the liver is enlarged, you must characterize it. There are 3 ways to characterize it. 1, you check for the length from the costal margin. So you come, you take your tape, you check the mid-clavicular portion, you trace it down to the costal margin. Along that mid-clavicular line, you now put your tape from the costal margin at the mid-clavicular line. Are you following? You now take a measurement to up to where the liver was enlarged. And you say the liver is 5 cm below the costal margin. That's the first thing. The second thing in characterizing it, you now palpate that liver. You check the surface, you check for tenderness, you check the edge to see whether it's smooth. Are you following? You palpate the liver, check the surface, you check for tenderness, you check the edge. The last thing to do to characterize it is to check for the liver span. How do you do that? You come to the chest, to the first intercostal space along the mid-clavicular line. You percuss along each intercostal space until you can hear the hepatic dullness. You mark that place with a Bible. Then you come down to the right iliac fossa. Along the mid-clavicular line, you percuss upward, until you also meet what? The hepatic dullness. You mark it. You now use a tape. You measure between the 2 markings. If what you get is above 10 cm, then the liver span is increased and it confirms that the liver is actually enlarged. But if what you get after percussing is less than 10 cm, the liver span is normal. And if the liver span is normal and you can feel the liver below the costal margin, it means it is not the liver that is enlarged. It's something in the chest that is pushing the liver downward, like emphysema or pneumothorax or hydrothorax, pleural effusion, and things like that. Is that clear? So that is what we do for the liver. Next, you examine the spleen. Please note, if the liver is not enlarged, will you be checking for liver span? No. If the liver is not enlarged, you won't be doing all those characteristics we were doing. It's only when the liver is enlarged. Is that clear? Now, after palpating the liver, you palpate for the spleen. The same method. You use the radial border of your index finger. You start also from the right iliac fossa. But this time around, the radial border of your index finger will face toward the left costal margin. Again, you ask the patient, breathe in and out. When he breathes in, you go in. As he breathes in, you go in. As he breathes in, you go in. As he breathes in, you go in, till you can feel the spleen or till you get to the left costal margin. But if you do feel the spleen, you will also characterize it. The way we characterize the spleen is to use your fingers to feel the edge and locate the notch. The notch is characteristic for the spleen. And then after that, along the mid-clavicular line, you measure the length from the costal margin. That is all we do. For the spleen, you don't do splenic span and you don't palpate the surface. Is it clear? Then lastly, on palpation for organs, you palpate for the kidneys. We actually ballot for the kidneys. What does that mean? You use the palm of your two hands. Your right hand will be anteriorly around the lumbar region. Please take note, around where? The lumbar region. If the examiner is looking at you and your hand is in the, what is it called? The hypochondriac region. Is it the spleen you are checking for? Everything you are doing, you may even get a minus. Is it clear? You check for this, so you check for the kidneys. You check for the kidneys in the lumbar region. Your left palm will be in the posterior aspect of the lumbar region, while the right palm is pressing down. The left one will ballot. Ballot means it taps like this. Do you see it? So if the one beneath ballots and then the kidney strikes the one on top, you say the kidney is ballotable. That suggests that it is enlarged. After doing on the right, you do on the left. Same thing, the right hand on top, the left hand from behind, and the left ballot. You see it? The left ballot. After that, we are done with palpation. We now go to auscultation. Sorry, to percussion. But like I said, let me quickly show you. I said, if you were given a case scenario, you may do some other things in palpation. Is it not so? What I have done so far is what we do in routine. But let's assume you have a case of obstructive jaundice. At that time, you are palpating for the liver. When you get to below the liver, you will use your fingers and be looking for the gallbladder, because the gallbladder can be enlarged in obstructive jaundice. So you are expected to always palpate for it. If you cannot feel it, you say it's not palpable. It's compulsory. If they give you a case of obstructive jaundice to do abdominal examination, if you don't report on the gallbladder, you lose mark. What of a case of gastric outlet obstruction? You are expected, after doing those routine organs, you are expected to come in the epigastric region stroke left hypochondriac to palpate for the stomach. Are you following? If you can feel it, you take the measurements. Then after that, you put your hands on the iliac crest. You grab it. You place your ears close to the left hypochondriac region and you shake the patient from side to side. That's what we call checking for succussion splash. If a patient has gastric outlet obstruction, you must check for that. Is it clear? If a patient has difficulty passing urine, you must be seen to palpate for the bladder. How do we palpate for the bladder? Like you palpate for the uterus. You come at the epigastric region, you'll be feeling like this, feeling for the dome, feeling for the dome. You go step by step till you feel the dome. When you feel the dome, you now try to see if you can get around it and get below it. Will you be able to get below it? No, because it's coming from the pelvis. Are you following? Then you measure the dimension in length. It's only one measurement from the symphysis pubis to the dome. You measure 1. Is it clear? Then after that, you percuss over it. From the epigastrum, you percuss downward till you get to about the pubic symphysis. If it is the bladder, the percussion nose will be done over the mass because the bladder will contain urine. Is it clear? So that is what you do. But you don't routinely do all this. So if they say examine the abdomen of this patient and you were not told whether the patient is jaundice, patient is having gastric outlet obstruction, patient is having difficulty passing urine, will you be doing all these ones I did? No. You just do the routine. Is that clear? If you do all those ones, you won't get extra mark. You may waste your time. They will ring the bell. You lose mark. Is that clear? So after palpation, you go to percussion. In the abdomen, you should note this. Percussion is done to assess for ascites. Percussion is done to assess for what? Ascites. We don't like we do in the chest. You know how we do in the chest? You percuss every region. Is it not so? We don't do like that in the abdomen. You don't come and be percussing each region. You don't do like that. Our percussion in the abdomen is to assess for ascites. So how do you do it? First of all, on your inspection, the abdomen must not have been distended. Because if the abdomen is distended, it means the ascites is massive. In such cases, we don't use percussion to locate the ascites. We use what we call fluid thrill. Is it clear? Demonstrate how that is done. So, but if the abdomen is not distended, you must percuss to assess for ascites. How is it done? You face the patient, you locate either just above the umbilicus or just below the umbilicus. You place your hand at the midline. You focus on the middle finger and you focus on the middle phalange of the middle finger. And you will use the middle finger of your right hand to strike as the hammer. Are you following? Are you following? If you choose to use your index finger versus index finger, you will not score any mark because that is not the method. Is it clear? So you come, you place your hand, you start from the midline, you percuss toward the side. You listen as you percuss for dullness. If you don't find any dullness as you percuss this side, you come back to the midline, you percuss to this other side. If you still don't find any dullness, you conclude there is no ascites. But if while you were doing this, you observe there was a dullness here, you leave your fingers there, you ask the patient to turn toward you. Turn toward me. Turn toward me. Then you still leave your fingers there, you wait for the fluid to settle. Then after that you start to percuss again. What was dull before will become resonant or tympanitic, as we say in the abdomen. Then you now go along that line to the midline. When you get to the midline, it becomes dull. That is what we call shifting dullness. And once you find that on one side, you don't need to check the other side. You conclude the patient has what? Ascites. Is that clear? After percussion, you auscultate. In the abdomen, auscultation is meant to check for bowel sound. In the medical exam, they will tell you things like checking for renal blue and so on. We don't do it in the surgical exam. Our only emphasis for auscultation is bowel sound. But when you want to check for the bowel sound, you will not do it like a native doctor. You know a native doctor does his own. You will just try the stethoscope in the left. If you do like that, you will not get the mark. You must first of all show to the examiner where you are putting your stethoscope. Is that clear? So you will come, you locate the umbilicus with one finger, then you run your finger along the iliac crest to locate the anterior superior iliac spine. Then in between the two, 1/3 of the way from the anterior superior iliac spine, or 2/3 of the way from the umbilicus. That is where you now put your stethoscope. and then you listen. Is it clear? So you must locate it before you put it. In the marking scheme, there are marks for doing that. If you don't do it, you lose those marks. Is it clear? Then after that, you are done with the anterior abdominal wall. The other aspect of routine abdominal examination is rectal examination. You must not forget. At that point, you now tell the patient to turn and take the left lateral position, bending the knees, flexing both knees. Most examiners will stop you and say don't bother, but they will give you the mark. Is it clear? Or you turn and face the examiner and say, sir, I want to do a rectal examination. They will tell you don't bother, but he will give you the mark. But if you just forget, you didn't make any attempt, they will not score you any mark for rectal examination. They may even give you minus for not doing it. So that's why you must be thorough and very thorough. Is it clear? In routine abdominal examination, we don't examine the urethra. But if a patient has, you suspect a patient has stricture, he has difficulty passing urine, or he has a hernia, you must examine the urethra. Is it clear? It's abdominal. The position is also anatomic position. The exposure, the patient remove and expose the entire chest. So we remove all his upper clothing. Is it clear? And then the steps are inspection, palpation, percussion, auscultation. And you examine anterior and posterior. Please don't forget, you also examine posterior. Is that clear? So how do we go about it? For inspection, you inspect the anterior chest wall, and then you put your hand on the pulse. I usually put my wristwatch here, but let me do what most of you do. You put your right hand on the pulse, you look at your wristwatch, and then you'll be looking at the chest, you count the respiratory rate. That is the teaching. Before you count respiratory rate, you must distract the patient. If you do like this and you count like this, you lose the mark, because that is not the technique. The technique for respiratory rate is to distract the patient by checking for what? The pulse. After that, inspection is completed. You don't really need to go to the foot of the bed. It's not necessary. Just inspect, and then you check the respiratory rate. After that, you go to palpation. For respiratory examination, we do 3 things in palpation. The first thing is to check for trachea centrality. In checking for trachea centrality, your index finger, your ring finger, you place at the medial border of both clavicle, and then your middle finger will feel for trachea centrality like this. That is the first step. Second step in palpation is to check for tactile vocal fremitus. How is that done? You use the radial border, the radial side of your hand. You place it over the upper, middle, and lower lung zones, comparing side to side. Another way to do it is to follow each intercostal space. But if you do that, you will kill your time. It's 3 minutes you have in the hospital. It is accepted in the books that if you check each zone, it will cover for all of the intercostal space within that zone. Are you with me? So you will share the lungs into upper, middle, lower. Then you ask the patient to say a word that will resonate. Like what? 99. When the patient says 99, you check this side. Then you check the upper here. You don't do one side complete before you come to the other side. That is not the technique. If you do like that, you lose mark. They can mark you up completely wrong. So you check upper, you compare with upper. Why patient say 99? You check middle, you compare with middle here. You check lower here, you compare with lower here. And you also check the side. You can do the side once. And then you also do the side here. After that, the last thing on palpation is to check for expansion. Again, you come the upper zone, you spread your fingers around to meet at the midline. And you ask the patient to breathe in and breathe out. And your tongue will move apart. Then you go to the middle, you ask patient breathe in, breathe out. Your tongue will move apart. You come to the lower zone, breathe in, breathe out. Your tongue will move apart. After that, palpation is complete. You go to percussion. For percussion, you do the same thing. Upper, middle. You don't have the time to be going through each intercostal space. You can do like that for them in medicine, but in surgery they will accept this for you. So you come in the upper, you percuss the upper zone here, you percuss the upper zone here, you compare. Middle, lower. Then you go to the side, upper, middle, lower. Is it clear? After that, percussion complete. You now go to auscultation. Who is disturbing us? You go to auscultation. Are you with me? In auscultation, the same thing. You listen at the upper zone. You compare with the upper zone here. You listen at the middle zone. You compare with the middle zone here. Lower zone. And the sides. Don't always forget the sides. Upper, middle, lower, and lower. After that, you are done with the anterior chest. You ask the patient to sit up. And then posteriorly, you won't do everything you have done in the front. 3 things you will do posteriorly. You check for tactile, vocal fremitus, you check for percussion, and you auscultate. So you compare again side to side. Compare side to side, side to side, side to side, side to side. You percuss comparing side to side. You always stay close to the midline at the back because the scapulars are in the extreme. So when you auscultate, you also compare side to side. You auscultate comparing side to side. After that, you are done with respiratory examination. The last one we're using for cardiovascular. Are you with me? Cardiovascular examination, the position is patient in cardiac position. So you must come to the bed and adjust it to cardiac position. Is it clear? If you are not able to adjust it to cardiac position, you tell the examiner, please sir, I would have loved to place the patient on cardiac position. Is it clear? Patient in cardiac position, the cardiovascular examination is in parts. The first part is to check the pulses. Second part, blood pressure. Third part, jugular venous pressure. The fourth part, the heart. The fifth part, the lungs. We check for basal repetition, because cardiovascular disease can cause pulmonary edema, and you will have fine basal crests. Is it clear? 5 parts in cardiovascular examination. So we start with the pulse. With the pulse, you use the pulp of your fingers. You feel the pulse. You note the rate, the rhythm, the volume. And then you bring the other one, you check for radio-radial synchronicity. Then you come to the femoral, you check radiofemoral synchronicity or delay, as the case may be. Other things they do in medicine are not important in surgery. Is it clear? You don't bother to do them. You just waste your time. You won't get marks for them. All those ones, they begin to palpate for the arterial wall, locomotor brachialis, collapsing. Those are for medicine. Is it clear? So for surgery, check rate, rhythm, volume, radioradial synchronicity, radiofemoral synchronicity. Then after that, you check for the blood pressure. If you go in the exam and you don't take your SPIG and they didn't put SPIG there, you will lose the mark for blood pressure. The HOD has told you carry a diagnostic bag along that you put 13 items, including toothpick, to use as what? For pinprick, is it not so? And then you should carry bedo, jaja, and achampon. So let's come back to cardiovascular examination. For the BP, you apply the cuff to cover 2/3 of the arm. And then I want you to listen. The first thing you do, you put your fingers on the radial artery, over the radial artery to feel the radial pulsation. And then you inflate the balloon while checking. When you notice you can no longer feel what? The radial pulse. Then you stop and raise it like 30 millimeters of mercury above before you apply your stethoscope. You apply your stethoscope on the medial aspect. That is where the radial artery is. Then you gradually deflate. Focus on the deflation. You gradually deflate. Gradually. And then you read the blood pressure. If you want to do it and you go straight and put your stethoscope without first of all checking the radial systolic, are you following? You will lose the mark, because that is not how blood pressure is done. Why am I making that emphasis? Because most people have learned the wrong thing because of haste. Is it not so? If you want to do blood pressure, you just jump, put stethoscope there, and you pump. Is that not what most people do? That's the wrong thing. The right thing is to first of all use your hand to palpate the radial pulse. Is it clear? Then after that, when you can no longer feel the pulsation, you know that's the estimated systolic. You raise it 20 or 30 millimeters of mercury above, then you now apply the diaphragm of your stethoscope, and then you now listen. And then when you are deflating, they must see you deflate what? Slowly. If you say you want to save your time, you just deflate once. Is blood pressure done like that? The examiner also will not give you the mark. Is it clear? So, you can do all this in 3 minutes. You learn it by practice. That's why we are doing this demonstration today, so that after now, you go home, form groups, and you practice. After that, we come to jugular venous pressure. Most patients in surgery will not have elevated jugular venous pressure, but you must show the examiner you are doing it. How do you do that? When it comes to that, you put your hand, you say, please look on your left, and then you inspect. Don't waste all your time there, because most patients don't have. So once you inspect, you cannot feel it, you say thank you, you keep the head back at the midline. Is it clear? And then you now come to the heart. For the heart, the first thing to do is inspection. You look to observe for precordial activity. They can ask you, those of you that will do short case, what is the precordial? Precordium. And what will you say? The precordium is the anterior chest wall over the area of the heart. That's the precordium. So it's more to the left, is it not so? And a little to the right. So you inspect for precordial activity. Most of our patients will not have. Then after that, you palpate. Palpation, you do it by placing your hand over the anterior chest wall, the precordial area, where you expect to find the heart. Are you following? You place it over what? The precordial area. Then you feel for the heartbeat. Then you locate the apex beat. After locating it, you come to count to know the particular spot. First of all, you come to the suprasternal notch. You run your finger along the sternum until you locate the sternal angle. You trace it to the side. That will be what? The second rib. Second rib is attached to the sternal angle. Then below it, you have the second intercostal space. Then you begin to jump ribs and count. That is second, this will be third, and this will be fourth, and this is fifth. Then you now trace down to this, to the point where you felt it, along the intercostal space, you trace down there, and then you trace upward toward the clavicle to know the part of the clavicle it is. Usually you find it in the fourth or fifth intercostal space in the mid-clavicular line. So that is what you do. Like I told you, and this is a secret, most of the patients in surgery do not have heart issues. So if you put your hand there and you are not appreciating things, rather than waste your time, you just locate what we know is normal for everybody and you quickly count it. Do you understand? You trace it down just around the nipple. That's where fourth or fifth intercostal space is. Is it not so? You quickly do that and move on. Then after that, do we have percussion for the heart? Do we percuss for the heart? No. You go straight to auscultation. So you start your auscultation from the apex beat you located. To auscultate for what? The mitral valve. Then in the lower sternal border, you auscultate for the tricuspid valve. Then you locate the sternal angle. Trace it to the left. The second intercostal space, you auscultate for the pulmonary valve. Then you trace from the sternal angle to the right. In the second intercostal space on the right, you auscultate for the aortic valve. After all that, the examination of the heart is completed. To complete cardiovascular examination, you tell patients sit up and you auscultate the base of the heart, of the lungs. The base of the lungs on both sides, for fine basal cracks which you can find in pulmonary edema that can occur with heart failure. Is it clear? After that, cardiovascular examination is complete and you tell your patient, thank you, you have done well, thank you so much. Clap for him. Examination, you examine the breast and every other organ that the breast cancer can metastasize to. To examine the breast, you follow inspection and palpation. There is no percussion or auscultation. Is that clear? For inspection, you squat in front of the patient and you ask the patient to put both hands by the side. You inspect both breasts for symmetry. Symmetry means you look at the size of this and the size of this to see whether one is obviously bigger than the other. Or you look at the both nipple-areolar complex to see whether there is an obvious change in one that differentiates it from the other. So that is what we mean by symmetry. The first thing to assess for is what? Symmetry. Second, the breast where you notice is different from the other. You now focus on that breast. And you look at the skin of the breast. Looking out for changes like distended veins, peeled orange, like orange peel. Multiple dimples like orange peel. You look for dimpling. You can just see a single dimple. It won't be multiple like peeled orange. You look also for nodules. Some small things like pimples on the breast skin. You also look out for ulcers. And you look out for obvious lump that you can see. So those are the things you will look out for in the breast. You also inspect the nipple-areolar complex to see whether there is nipple retraction, whether there is ulceration of the nipple-areolar complex, or whether there is obvious discharge from the nipple. So you inspect all of that. In this same position with the arms by the side, you inspect the supraclavicular region for any swelling because there may be lymph nodes there. And you also inspect the arm on the affected side. There may be lymphedema. After inspecting with the arms by the side, you ask the patient, place your hands above your head. When the patient does that, you now inspect the lower aspect of the breast. For most patients, when they raise the hands up, you will see the lower aspect. But for some patients that the breast is very pendulous, even with raising the hands up, you will not still see the lower aspect. So what do? You come, using the dorsum of your fingers, you raise the breast up and you inspect the lower aspect. Is it clear? Because sometimes there may be a lesion on the lower aspect. So you inspect like that for both of them. In this same position, you inspect both axilla for axillary lymph node enlargement. Then after that, you ask the patient to put the hands on the hip and press. While she's pressing, you still inspect both breasts. The point is that all these motions will make a lump that was not visible while the hands were by the side. When the patient raised the hands up or press on the hip, that tenses the chest, anterior chest muscles, the pectoralis, latissimus dorsi, and that can make a lump more prominent. So after that, inspection is completed. You now ask patient to lie down. You palpate the breast with the patient lying on a pillow. Put your legs down. Are you with me? With the patient lying on a pillow. It may not necessarily be cardiac position. Do you understand? Because we have used that for cardiovascular examination. But at least you must give the patient a pillow. Now, you start palpation from the normal breast. So let us assume that there is a lesion in the right. Let's create a lesion. Please, just tuck this in under your, not into the brow. Just on top. Correct. Do you appreciate the lesion? Okay. Focus, please. Let's assume there is a lesion on the right. So we will start our palpation from where? From the left. If you want to palpate a breast, you first of all ask the patient to place the palm of that side under the occiput. You use the flat of your hand, the palmar surface of the fingers, to palpate the breast. And you do it systematically and professionally. Do you understand? You are to palpate 6 areas. How do we get those 6 areas? You take an imaginary line through the nipple horizontally, an imaginary line through the nipple vertically. That will give you upper outer quadrant, lower outer quadrant, lower inner quadrant, upper inner quadrant. How many? 4. Then a central area making what? 5. And the axillary tail making 6. Those 6 areas are what the examiners are looking at you to palpate. You are not to come and just be rubbing your hand around the whole breast. That will not be breast examination for surgical examination. That is another thing. Are you with me? So let's go. Look at it. You don't poke. Is it clear? Your hands will be flat, like I told you for abdominal examination. So you come. You can start from anywhere you like, but you must touch those 6 areas. And this is what you do. You lay your hand on that part and you rub it against the chest wall to see whether there is a lump. Then you do another part, the 3rd one, the 4th quadrant, the central area, and the axillary tail. Is it clear? Since this is the normal area, it will afford you the knowledge of what is normal to the patient. So that when you come to the abnormal area, you will be able to spot the difference, especially where there is no obvious mass, like all those young girls that have fibroadenoma. They also bring them for the exam, long case or short case. Is it clear? So both breasts may look the same because it's a small thing inside. So when you go through the normal, when you come to the abnormal one, you'll be able to spot the difference. But I advise you for such, if it's long case, tell the girl to show you. Do you understand? But if it's short case, the examiner is looking at you. There is no time to say, show me. If you say it, he will hear. You know, so that's why you must carefully know what is the normal so that when you come to the abnormal side, you'll be able to spot the difference. Is that clear?
Yes, sir.
So after palpating those 6 areas, you now express to see whether there is a nipple discharge. After that, the examination of the breast is complete. You now take, give me your left hand to left hand, you are examining the left axilla. Are you with me? So like we said before, medial, anterior, posterior, lateral, central, apical. We have demonstrated that before. You rub that place against the bony or muscular wall behind it to see whether there are enlarged lymph nodes. Is it clear?
Yes,
So after you have done the normal, you now come to the abnormal. This is where you really focus. Again, you ask the patient, place your palm under the occiput. The first thing you do is to examine the breast. After examining the breast, before you now examine the breast lump. Do you appreciate what I've said?
Yes, sir.
Sometimes the mass can spread to occupy the whole breast, but you must be seen to have first of all done breast examination. What is breast examination? You palpate the 6 regions and you express for what? Nipple discharge. So you come, upper outer quadrant, you apply pressure, you rub against the chest wall. Lower outer quadrant, lower inner quadrant, upper inner quadrant, the central region, and the axillary tape. So while doing all that, you would have located the mass. Are you with me? Are you okay? While doing that, you would have located the mass. You can quickly express to see whether there is nipple discharge, and you know you are done with breast examination. Then you now focus on the breast lump. How do we examine the breast lump? Like every other lump, you start with differential temperature. You come to the normal, you touch the normal, you touch this abnormal, and you touch the normal again. That gives you differential temperature. Then the next thing is to check for tenderness. While looking at the patient's face, you touch the lump in 2 places and see whether it is tender. Are you with me? Then after that, you measure the size, at least in 2 dimensions, perpendicular to each other, that is vertical and horizontal. You take your tape, you measure horizontal, you measure vertical. If the mass is very big as to have a height, you also measure the height. Is it clear? Is it clear?
Yes.
Vertical, horizontal, and height. Height, if it has a height. Is that clear?
Yes.
After that, the next thing you do, so you then measure the length, the breadth, and the height. After that, you palpate the surface of the mass. Using the palmar aspect of your fingers, you rub gently to see if it is smooth or it is nodular or irregular. Then after that, you palpate the consistency. To do that, using the pulp of your fingers, you press on the swelling, pressing it against the anterior chest wall. Do you understand? You'll be able to appreciate whether it is hard or firm or soft. Cancers are usually hard. How do you know soft, firm, or hard. If you touch your lips, it is soft. If you touch the tip of your nose, it is firm. If you touch your forehead, it is hard. So what you feel, if it looks like the lip, it is soft. If it looks like the feel of the tip of the nose, it is firm. If it looks like the feel of the forehead, it is hard. So you check consistency by pressing with the palm of your fingers. Is it clear? Then after that, you check the edge of the mass. The reason you check the edge is to see whether the mass is free from the rest of the breast. If it's a benign lesion, it will be free. But if it's malignant, it will not be free. It will appear to infiltrate into the rest of the breast. Is it clear? Is it clear? So you check the edge. Then after that, the next thing to do is to check for skin attachment. You try to pinch the skin to raise it above the mass. If you can raise the skin above the mass, then it means the skin is not attached. If you try to raise the skin and you cannot, then the skin is attached to the breast. After that, you check for mobility by moving that mass side to side and up and down. Is it clear? You check for mobility by what? Moving the mass side to side and up and down. If the mass is mobile, you will also check for attachment to underlying structure. If the mass is not mobile, already it means it is attached to underlying structures. Is it clear? Is that clear? So if you move it, you try to move it, you see it's not mobile. Side to side is not mobile. Up and down is not mobile. What does that mean? It is attached to the underlying pectoralis muscle. But if you move it side to side and it's mobile, you move it up and down, it's mobile. You now ask the patient, put your hand on the hip and press it. Press on your hip. Then first of all, you come and check the muscles that enter the humerus through this axilla. You check it here to see that they are tense. When you can confirm they are tense, you now come back to move the mass side to side and up and down. If the mobility is reduced, it will mean that it is what? Attached to the underlying muscle. But if it is still mobile side to side, mobile up and down, it is not attached to underlying muscle. After that, you now examine the axilla on this side, like we have described before. Medial, anterior, lateral, posterior, central, apical. Is that clear? Is that clear? Then after that, you put your hands into the supraclavicular region and you, are we okay? Yes. You palpate for what? Supraclavicular lymph nodes, because breast cancer can cause enlargement of supraclavicular lymph nodes. So you palpate for supraclavicular lymph nodes. Then after that, you take your stethoscope, you auscultate the anterior chest, upper, middle, lower. Is it clear? You won't do full respiratory examination. You are just looking for signs of metastasis to the lungs or the pleura. So you just listen to breath sounds. If they are normal, no metastasis. But if breath sounds are reduced on one side, especially the side that is affected, what does it tell you? there may be some metastasis. Is that clear? Then after that, you tell patient to sit up. While patient is seated, you auscultate the back, upper, middle, lower. Then you run your finger along the midline. Are you with me? Along the spine. While looking at the patient, one, you check for if there is any swelling or there is any depression along the midline. And you percuss over it also, checking for tenderness. If there is metastasis to the spine, there could be a swelling along the midline, or there will be a depression. If the cancer is destroying the bone, there will be a depression, or there will be a swelling if it is causing a growth there. Do you understand? Then some can also show as tenderness. That's why you also percuss over it to see whether there is tenderness. Is that clear? So at the back, first you auscultate upper, middle, lower. Then you run your finger along the spine to see whether there is a swelling or a depression. You percuss the spine to see whether there is tenderness. You look at the face of the patient as you are percussing. After that, you ask the patient to lie down again. You now palpate the 9 regions of the abdomen, palpating for masses. Do you understand? The way we have done before, you palpate for masses. Then after that, you examine for the liver, like we have taught before. Then after that, you percuss for possible ascites. Then after that, you ask the patient, can you walk? If you say yes, you tell patient, get down and walk, and you assess for gaits. If you say, can you walk? And you say no, you now assess for power, muscle power in the lower limb. Do you understand? If you say raise your leg, he cannot raise the leg. He makes effort, he cannot raise it. You just see flickers of movement. That will be grade 1. If they can move it side to side, that will be grade 2. If they can raise it up against gravity, that will be grade 3. If you can resist minimal resistance, that will be grade 4. Somebody who has grade 5 should be able to walk. Is it clear? Can you walk? Get down, walk. So you now assess for gait. You assess for gait. Thank you very much. In an adult, if you want to examine a hernia, first you will examine the groin swelling. Second, you will examine those other regions of the body where the etiology of the hernia could lie. Is it clear? For the groin swelling, you start in the standing position. You can meet the patient lying down, but once the examiner tells you, examine this hernia, you excuse the patient to stand up after you have greeted and taken permission and done all those things. Is it clear? So you stand by the right hand side of the patient. You squat and you inspect not only the side you can see the swelling, you also inspect the other side. So you should be seen to inspect the whole groin down to the scrotum. Is it clear? So you note the site, the anatomic site of the hernia, and the extent of the hernia, if it extends into the scrotum. When we say extent, we are concerned about the scrotum. So you look, inspect the groin, the entire groin, and the scrotum. You note the anatomic site. That is, whether it is the right groin or the left groin. And you look at the scrotum to see whether the swelling extends into the scrotum. Then you also note the shape of the swelling. And then you look at the surrounding region to see whether there is a previous scar, to show whether a surgery has been done before. You inspect for previous groin scar. After you have looked at all that, you tell the patient, turn to the other side. But if your examiner is there, please don't tell the patient to turn to face the examiner. Just let the patient face forward. Is it clear?
Yes.
So turn to the other side. Cough. Let's be serious, eh? Cough. When the patient coughs, you observe for visible expansor cough impulse. You know what I mean by that? When the patient coughs, the hernia will expand. It will expand. Do you understand? Because this is a makeshift, it's not expanding. But normally what you find is that as the patient coughs, the hernia will what? Expand. If you don't do that, you will score minus because it is diagnostic for hernia, a visible cough impulse. Is that clear?
Yes.
After that, you go to palpation. Again, as usual, palpation starts with differential temperature. You come to the other side that does not have a swelling, you touch it, you touch the swelling. Then you touch the other side again. That is all the motion. Please note, you don't start from the swelling and go to the other side and come to the swelling. If you do like that, it is wrong. The proper thing for differential temperature, differential warmth is to start from normal side, abnormal, and then normal side. After checking for differential temperature, second thing you do in palpation is to check for tenderness. You stick out your index finger, look at the face of the patient, you touch the swelling in two places and see whether there is sign of tenderness. Most times hernias are not tender except they become complicated. Is it clear? Then after that, the third thing, you estimate the size. Take your tape, measure horizontal, measure vertical, at least 2 dimensions. If you can add a third, the height, you do. But if not, you must at least measure in 2 dimensions. Is that clear? Then after that, you come to palpate. For hernias, we are not particular about surface. Is that clear what I've said? In your palpation, you go straight to check for consistency. You put your hands, your fingers on the hernia, you put your fingers on the hernia and you dig the pulp against the body to feel the consistency. Hernias usually will be soft. Do you understand? They will be soft. So you feel the consistency all around like that. After that, Because they are soft, you will not check for what we call fluctuancy. If a swelling is soft, you must check for fluctuancy. If a swelling is firm or hard, you don't bother to check for fluctuancy. Because hernias are usually soft, you will check for fluctuancy. How do you check for fluctuancy? You grab the swelling in the horizontal plane and you bring your index finger, you press the dome. As you press the dome, it will displace the other fingers. Like this, you press the dome, it displaces the other fingers. So you do in the horizontal plane, it displaces the other fingers. You also do in the vertical plane. Can you see it? You press the dome, it will displace the other fingers. As you press it, it displaces the other fingers. That tells you it is what? Fluctuant. Then because it's fluctuant, you check for trans-illumination. Where is the touch? The pen touch. Pen touch. You check for trans-illumination. Pen touch, fold of paper, quickly. Where your pen touch? Fold of paper. It's best to use a colored paper, not a white paper. Is it clear? So, you should have done the fold of paper before the exam. Is that clear? Something smaller than this. Do you understand? So, after checking for fluctuancy, you come, put the touch on one side, and put the fold of paper on the other side, and you look inside the fold of paper. If you see light just around the skin where you are putting your touch, that is not transillumination. Transillumination means when you use your fold of paper to look in another part, as you look inside, you still see the light. Is it clear? Usually hernias do not transilluminate. Is it clear? So after doing that, the next thing to do is to palpate the scrotum and see if both testes are palpable. Is it clear? Is it clear? You palpate the scrotum and see whether both testes are palpable. Then after that, you now palpate if it's a swelling, if it's a hernia that entered into the scrotum. Are you listening? You palpate the spermatic cord to confirm that that hernia is extending into the inguinal region, as in you cannot get above it. Is it clear? But if it did not enter the scrotum, you don't bother to do that. All you will just do is palpate for the testes. Is it clear? Yes. So after that, you now come, you place your hand over the swelling. You tell patient turn to the other side and cough. Then you now feel for palpable cough impulse. Is it clear? Yes. Then after that, you ask the patient to lie down. You continue the examination in the lying down position. I just quickly recap. Inspection, you look at the swelling, you know the site, you know the shape, you note whether it's extending to the scrotum. You look at both sides. Then you ask patient cough. As patient coughs, you note a visible cough impulse. Then you palpate, first checking for differential temperature. Then you check for tenderness. Then you measure the size at least in 2 dimensions. Then you check the consistency. Usually it will be soft. Then you check flopped once in 2 plates. Then you take the fold of paper, you put the torch on one side and you look from the fold of paper on the other side for transillumination. After that, you palpate the scrotum, you palpate the testis in the scrotum. If the swelling extends into the scrotum, you also palpate what? The spermatic cord. But if not, you don't bother. Then you come, place your hand over the swelling, ask patient to cough. When you cough, you feel for what? Palpable cough impulse. Then you now tell patient lie down.
Are you taking your patient?
Lie down.
Yes.
Now, when the patient lies down, when the patient is laid down, you check for reduction. First, you just inspect. Some hernias will reduce spontaneously. As the patient lies down, it will just reduce spontaneously. If it is so, you report it so. But if it didn't reduce, you will now reduce the hernia. How is the reduction done? You grab the hernia at the dome. You apply some gentle pressure at the neck. You'll be squeezing it from the dome and applying some gentle pressure at the neck. The intestines or whatever is the content will gradually be going into the abdominal cavity, until all of it is gone. Then after all of it is gone, you now do what we call ring occlusion test. That helps you to differentiate indirect inguinal hernia from a direct inguinal hernia. The indirect inguinal hernia usually passes through the deep ring, the internal ring. So when you succeed to reduce the hernia, you do ring occlusion test. That therefore means if you cannot reduce a hernia, can you do ring occlusion test? No, you can't do it again. But let's say we have reduced it, the hernia is not there again. You now come to locate the deep ring. How do you locate the deep ring? You use your right hand, place your middle finger. Can you see it well? You place your middle finger on the umbilicus. You trace it down to the pubic symphysis. Your left hand on the iliac crest. You scroll anteriorly till you locate the anterior superior iliac spine. Now, midway between both of them, you locate your index finger. Are you with me? Then you place your middle finger at that point to take a finger breadth above the mid-inguinal point. When you take a finger's breadth above it, that is where the deep ring is. You now occlude with your index finger. Then you ask the patient to cough. When the patient coughs, if the swelling did not protrude again, you say it is what? Indirect inguinal hernia. Because you're occluding the deep ring prevented it from what? Coming out. But if while you are occluding the deep ring, the patient coughs and the swelling still protrude, usually medial to your finger, you will conclude that the patient has what? A direct inguinal hernia. I go over it again. After reducing the hernia, place your middle finger on the umbilicus, trace it down to pubic symphysis. Your other hand, are you seeing well?
Yeah.
Okay. Your other hand on the iliac crest, you trace it to the anterior superior iliac spine. The midway between the two, you locate midway between the two. Is it clear? You put a finger's breadth at that mid portion, and then you take your finger above the finger's breadth, and that's where the deep ring is. You ask patient cough. If the swelling did not come out, it's indirect. If the patient cough and the swelling comes out, it is what? Direct. Another way some other people do this is to use the pubic tubercle. So whichever you do, they are right. Those that use the pubic tubercle, after putting the finger on the, the umbilicus, they trace it to the pubic symphysis. Then they palpate laterally from the pubic symphysis. The first bony prominence is the pubic tubercle. They now use the pubic tubercle and the anterior superior iliac spine. Midway between, are you following? It will still be about the same place. You now take a finger's breadth above that and locate the deep ring. Is it clear? But just using the pubic symphysis and anterior superior iliac spine are simpler. Is it clear? So after that, are you with me? After that, you now examine the other areas of the body where the etiology of a hernia could be located. Please concentrate. Are you with me? So you come, you start from the chest. You start from where? The chest. You auscultate. You don't do full chest examination. You auscultate upper, middle, lower, side, like we did before. Then you come to the abdomen. You palpate for masses in all those regions. You palpate for masses. Then after that, you come to the phallus. You lift it up. You lift up the phallus, and then let's assume this is the phallus. You palpate, you can run your finger along like this to palpate the ventral surface of the phallus where you have the urethra. Are you following? Now, if this is the phallus, you run your finger down along the penile urethra. You get to the median raphe of the scrotum. You continue through the median raphe till you get to the perineum. Then you stop. Then after that, you ask the patient to lie on the left lateral position. You examine for the prostate, especially if it's a male, because when there is enlarged prostate causing difficulty passing urine, it can predispose to hernia. There's abdominal masses, it can predispose to hernia. Chronic cough can predispose to hernia. Urethral stricture can predispose to hernia. That's why you must check all those areas. It is after you have done all those ones that your examination is what? Complete. This is not usually done. But if you are in a short case exam, they may ask you, how can you differentiate inguinal hernia from femoral hernia? It is not usually done. But if you are asked, the way to do it, you locate the hernia. First of all, you put your finger on the umbilicus, trace it to the pubic symphysis, then feel laterally till you locate the pubic tubercle. When you locate the pubic tubercle, you now trace the hernia to the neck and see the relationship of the neck of the hernia to the pubic tubercle. If it is superior and medial, it tells you it is inguinal hernia. But if it is inferior and lateral, it tells you it is femoral hernia. I go over it again. If you are asked to differentiate between inguinal hernia and femoral hernia, how do you do it? You locate the umbilicus, trace it down to pubic symphysis, scroll laterally to locate the pubic tubercle, then trace the neck of the hernia to the swelling. If it is superior and medial to the pubic tubercle, you say it is what? Inguinal hernia. But if it is inferior and lateral to the pubic tubercle, you say it is what? Femoral hernia. So that is hernia examination. Is it clear?
Yes.
Thank you. You thank your patients. So please concentrate. If you want to examine a patient with goiter, like this patient you see is using glasses, you ask the patient to please remove the glass, to remove a hair tie, to remove a necklace, and whatever she is putting on. Can you remove this jacket? Can you? Okay. So, goiter examination is done in the sitting position. Give them the glass too. Goiter examination is done what? In the sitting position. You take a chair and ask the patient to sit on the chair, not on the bed, because you must be able to go behind. Is it clear? You start the examination with the neck mass. After examining the neck mass, you will examine for eye signs. Then you examine the upper limb for some signs. And you end by examining the lower limb for some other signs. So for the neck mass, you follow inspection, palpation, and percussion and auscultation. You have the four of them complete for goiter. You have the four of them. So I want you to look carefully how we are going to do it. One problem with goiter examination, the steps are very many, and you are expected to do them for 3 minutes. And it's very possible. When you have practiced it over and over again, it becomes very easy. So to start, you start with inspection. You squat in front of the patient and you inspect the neck mass. You note the site. If the neck mass is very big and you can't see it very well, you tell the patient to extend the neck a bit. But if the patient is positioned in its normal position and you can see it well, you go ahead. First, you inspect to note the site, the shape, the skin over the swelling. Sorry, before that, you note the number of the swelling, the site, the shape, whether it is solitary, that is single, or whether it is several, more than one. Then you note the skin over the swelling, and then you look at the surrounding skin. You look at the surrounding skin to see whether there are other swellings around that could be lymph nodes. Now, if you are doing husky, you do all this very fast. You don't waste your time. Is it clear? You look, you note the site, the shape, the number, the skin over the swelling is usually normal in a goiter, and then you look at the surrounding to note whether there are other swellings around. After that, you ask the patient to swallow. You must not forget that. It is diagnostic for goiter. You ask patient, swallow. Usually, goiters will move with swallowing. The next thing, you ask the patient, open your mouth. Bring out your tongue. 2 steps. Open your mouth, bring out your tongue. You don't say bring it at once. As the patient do that, you observe the swelling if it moves with tongue protrusion. Usually, goiters do not move with tongue protrusion. Is that clear? Is that clear? After that, inspection is complete. So if you were doing an OSCE exam, once you come, you just look. Don't waste time. Say, swallow. Because those other things, you see them once. Except you are doing an exam where you are going to report your findings. That's when you'll be taking notes to see what is really going on. But you can note all of those things once. You just come in front of the patient, you look, you say swallow. Then you say open your mouth, bring out your tongue. You don't waste time. That is what? Inspection. After that, you go to palpation. Palpation, you do some parts of the palpation in front of the patient. You do the rest of the palpation behind the patient. Don't forget that. You start to palpate in front and you continue behind. In front, you palpate for 5 things. I remember them with 4 T's. When I say 4 T's, I write 4, I write T, I write S. So the 5 things are T, 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 S. Do you get it? The first one is temperature. You check it in the front. So you come to the hand, you touch it, and you touch the swelling, and then you touch the hand. Is it not so? Normal, abnormal, and back to normal. It is not accepted for you to use the chest. Do you know why? Because goiter can extend into the chest. That is one mistake some candidates make. So you must come to the arm or any other part of the body. Is it clear? After checking for temperature, you check for tenderness. You stick out a finger, looking at the face of the patient, you touch the swelling like in 2 places and see whether the patient show pain. You could also first of all ask the patient, is it paining you, before you now do the tenderness. But if you don't, they don't bother so much like in abdominal examination. Is it clear? So after differential temperature and tenderness, the next thing to check for is the tracheal position. Like we did for chest examination, you can do it like this. You put the index finger there and then you try to use this to locate it. Can you see the difficulty? Can you see the difficulty? So that can be difficult. So when you are dealing with goiter, it is accepted for you to stick out 1 finger and use it to locate the trachea. Are you following? And then as you are going, you run the finger through the mass, pressing in to see if you can feel the trachea until you get to the suprasternal notch. Is it clear? Is it clear? To locate the trachea, 1 finger, you put it, you run it through. Then after that, the next thing to do is to check for tethering. That's the other T, tethering or skin attachment. So you come to the skin above the swelling, you try to pinch it to see if you can raise the skin above the swelling. Most times, goiters are not attached to the skin, except if it's malignant and it has advanced. Is it clear? So they are not attached to the skin most of the time. After that, the next step is to now measure the size, that is the S, 4TS. Are you following? 40s. Temperature, tenderness, tracheal position, tethering, and size. To measure the size, first of all, you check the extent. You check it on this side, above, this side, and this side. When you now make out all the margins, you take your tape, you measure horizontal, you measure vertical. Horizontal and what? Vertical. If it has a height, you add the height. But at least your measurement must be what? 2 dimensions. Is that clear? Is that clear? So after doing those 5 things, you now go behind the patient. You go behind the patient. Come over. Behind the patient, your thumb, you place. Somebody who has a touch. Come and show touch here. Let's see the occiput. Be fast. Quickly. When you go behind the patient, think this. You place your thumb like this. Your thumb on the So you place your thumb on the occiput. Have you got it?
Yeah.
So you can go that way.
Okay.
You can go. Leave it. So your thumb on the occiput and your other fingers in front of the neck. Are you getting it well?
Yes.
Okay. Your other fingers in front of the neck. Are you with me? So while behind the patient, the first thing you do on palpation, you ask the patient to swallow again. As the patient is swallowing, you note the swelling moving upward, and then as it's moving upward, you try to see if you can put your fingers. Can you see? If you can put your fingers below it. If your fingers can get below it like this, it tells you there is no retrosternal extension. But if while the patient is swallowing and is moving upward, and you find out that as it's moving upward, it's like your finger is still on the mass, moving along with the mass, it tells you there is retrosternal extension. As the one you could see was going up, the one below was what? Coming out. And that is what appeared to carry your finger along. And so your finger cannot get below. That tells you there is what? Retrosternal extension. So the first thing when you get behind, you place your thumb on the occiput, the fingers in front, ask patient swallow. As he swallows, the mass goes up, you see whether your finger can get below. If your fingers get below, there is no retrosternal extension. But if your fingers cannot get below, there is retrosternal extension. So you are focusing on what my fingers are doing. Okay. After that, you still put your hand over, you ask the patient, open your mouth, bring out your tongue, and you confirm that it does not move with what? Tongue protrusion. It does not move with tongue protrusion. Then after that, you now palpate each of the thyroid lobes, the right and the left, one after the other. To palpate each of the lobes, first of all, you ask the patient to flex the neck a bit. Did you notice that? You ask the patient to what? Flex the neck a bit. Let's assume I want to start with the right side. Are you with me? You now tilt the head to the right side before you start to palpate that side. Now, why do we do all this? The patient flex a bit to relax the strap muscles. You tilt the head to the side you want to palpate to relax the sternocleidomastoid muscle on that side. Is it clear? Now when you want to palpate, this your left hand will stabilize the left lobe. You even put this your index finger on the jaw so that the patient does not raise the head up. Then your other hand will focus on the right lobe. These other fingers will stabilize this. They are not palpating. They just stabilize to make sure your palpation here does not push away. Do you understand? Do you understand? Then you now come with this, your hand on this lobe. First of all, you feel to see whether there is any swelling. Are you following? Are you following?
Yes.
Just like this. You rub like this to see whether there is any swelling. Because this is not a proper goiter. Are you following? It's giving some difficulty as you are trying to do your moving up and down. But that's what you normally do. When you do like that, you now locate a swelling. The next thing you do, you feel for the consistency by digging your fingers into it. Usually goiters are firm. Goiters are what? Firm. They become hard when they are cancerous, and they become soft when they are inflamed. But usually they are what? Firm. Is it clear what I've done? First thing, to palpate the right lobe, you check for what? If there is any swelling. And then if you get a swelling, you press like this for consistency. Then after that, you tilt to the other side. This one will now stabilize this, and this one will now palpate this other side. And when you now check this side like this, you see that, oh, there is no swelling here. Will you be checking for consistency again? No. But let's assume the swelling was general. You will still, when you check, you also feel what? A swelling here. You also check for what? Consistency. But it is not always you have the swelling on both lobes. Are you following? So that's why you first of all check whether there is a swelling on that lobe. Then you check consistency if there is a swelling. But if this was to one side and you check this side that there is no swelling, you don't bother to check consistency. Is that clear?
Yes, sir.
After that, the next step is for you to grab the swelling. You grab the swelling, you move it side to side to see whether it is free from the sternocleidomastoid muscle. You move it side to side. If you cannot move it side to side, it tells you it is what? Already extending into the sternocleidomastoid muscle. But if you can move it side to side, then you now put the sternocleidomastoid muscle. So you move the mass side to side to you stabilize the head of the patient while you do that. Why are we moving it side to side? To see if it has extended into the sternocleidomastoid muscle. If it has extended, it will not be mobile. Do you understand? Then after that, you put the sternocleidomastoid muscle under tension. One way to put both sides under tension at the same time, you put your hand under the jaw and you ask the patient to press on your jaw. Press on my hand. As he's pressing against it, it tenses the sternocleidomastoid. You now try to move the mass side to side again. If the movement is now reduced, it tells you it has what? Extended into the sternocleidomastoid muscle. But if it's still freely mobile, you know that what? It is not extending into the sternocleidomastoid muscle. Because the sternocleidomastoid muscle forms the lateral border of the thyroid gland. When a goiter is enlarging, it can enlarge and insinuate into the sternocleidomastoid muscle. So that motion is what we use to check whether it has extended into it. Is that clear? Then after that, the next thing you do is to palpate for the carotid arteries. You do them one at a time. To do one side, if I want to do the right, you place your left hand on the head of the patient and you check the right. If you do both at the same time, you can mistakenly occlude both and the patient will suffer a syncope. Because if you occlude the both at the same time, there will be no blood supply to the brain. Patient can faint. Because of that, the teaching is that you must not do both at the same time. So you must show to the examiner that you are not doing both at the same time. One way to show that is that you put your hand on the head of the patient. If you put your both hands like this, you may not be doing both at the same time. But if the examiner is this way, will he see that you are not doing this? He will not see. So he can assume you are doing both and he will mark you down because surgeons frown at it. Surgeons frown at it because if you mistakenly occlude both, you make your patient to have syncopal attack. So you place one hand on the head of the patient and then the other hand you come to the midline. To the midline, you extend your finger to the angle of the jaw and then you feel the carotid pulsation. You put the right on the head of the patient and then you come again to the midline, extend your fingers to the angle of the jaw and feel the carotid pulsation. If the carotid pulsation is not palpable, you say the patient has Berry sign, B-E-R-R-Y, Berry sign. When the carotid pulsation is not palpable, you find that in malignant goiters. When the malignancy of the goiter has infiltrated the carotid sheath, the carotid artery will no longer be palpable. Berry sign. So after checking the carotid artery pulsation, the next thing to check is the neck lymph nodes. You start from the submental, submandibular, pre-auricular, upper cervical, middle cervical, lower cervical. You ask patient to raise the shoulders, you check supraclavicular, then you come to post-auricular, and then you end with occipital behind. Everything behind the patient. Is it clear? Is it clear? After that, you are done with palpation. You now come to percussion. You don't percuss over the mass. You percuss the upper chest from the sternal angle upward. You come to the sternal angle. You percuss upward. Why are we percussing? Because if there is retrosternal extension, the percussion notes become dull. You know that percussion note in the chest is usually resonant because of the air in the lungs. But if you come and percuss from the manubrosternal junction upward to the sternal notch, if the sound is dull, it tells you there is a retrosternal extension. So that is where we percuss. We don't percuss over the mass. We percuss the upper chest. From where? Manubrosternal junction to the sternal notch. After that, you auscultate. You auscultate using the bell. You auscultate using the bell. Your auscultation is to listen for thyroid artery blue. You use the superior thyroid artery. You don't auscultate over the goiter itself. This is wrong. You come at the superior pole of the thyroid. You auscultate on this side, and you come, you auscultate on this side using the bell. After that, the examination of the goiter itself is completed. You now come to the scalp. You come to the scalp, you palpate the scalp. You palpate the scalp to see whether there is any swelling of over the scalp. Why do we do that? When there is malignant goiter, it can send metastasis to the scalp. Is it clear? Then after that, you go to check the eye signs. You start the eye signs from behind, checking for proptosis. You check for proptosis from behind. Most of the eye signs are named after people. If you remember the names, good, but if not, you should know what you are checking. Is it clear? But in the OSCE exam, you don't talk. Sure, you know. You just be doing what you are doing, they'll be marking your steps. But for the dentals, after you finish, you will report your findings. So you must know what you are doing, so that you know what to report. So we go to eye signs now. The first one is proptosis. The sign is also called Naff-Zieger's sign. How is it done? You take the head of the patient like this, you extend the neck. After extending the neck like this, you now look at a tangent. You don't extend and then look straight like this. It will be wrong. Is it clear? This is what? Wrong. As you extend, you adjust your head and you look at an angle so that you are seeing this eyebrow. Are you following? Is this not called eyebrow? You are seeing the eyebrow. Now if you look like that, you should not normally see the eyeball. But if you now start to see the eyeball like that, you say the patient has what? Proptosis or Naff-Zieger sign positive. So that is the first eye sign you check. After that, you now come in front of the patient. You stay on the right hand side. You place one hand on the head of the patient to stabilize the head of the patient, so that the patient will cooperate with the signs. If you don't put your hand on the head of the patient, when you are moving your fingers, the patient will be turning the neck and you will not get what you're supposed to get. So you place one hand on the head of the patient, you place one finger at eye level, not too close to the eyes. You give some distance. Place one finger in front of the patient. You ask the patient to focus on your finger, and then you look into the eyes of the patient. You note 3 signs by just inspecting the eyes of the patient. Number 1, you look at the sclera, looking for conjunctival edema, because it's common in patients that have exophthalmos. Is it clear? Conjunctival what? Edema. You will see the conjunctiva will be swollen and reddish. That's the first thing you look for while you are inspecting the eyes with the patient focused on your finger. The second thing you look out for is what we call staring gaze. If you have been looking at this patient, you see she has been blinking the eyes. Somebody that has exophthalmos will not blink. She will just be looking without blinking. You call that what? Staring gaze. It's named after somebody. If you find that, you call it Stellwag sign. Is it clear? Stellwag what? Sign. Stellwag sign. Then the third thing The third thing that you look out for while the patient is focused on your finger is to look out for upper lid retraction. Upper lid what? Retraction. If you find it, you call it Dalrymple's sign. Don't make noise, please. You read it in the book later. Dalrymple's what? Sign. Upper lid retraction. What do we mean by upper lid retraction? Normally, when you are looking at eye level, you cannot see the white of the eyes above the black. You cannot see the sclera above the limbus. Are you following? But if you were seeing something like this in this patient, the sclera above the limbus, you say the patient has what? Upper lid retraction. Is it clear? But now, as the patient is focused on my finger, we cannot see the white, so there is no upper lid retraction. Is it clear? Is it clear?
Yes, sir.
So when you come in front of the patient, the first thing, you put your finger in front, stabilize the head, and tell patient focus on your finger. You inspect for those three signs. Number 1, conjunctival edema. Number 2, staring gaze. Number 3, upper lid retraction. After that, you ask the patient, please follow my finger. Look at it. Look at my finger. Follow it. Follow it. Look at it. Follow. When you see wrinkling, you stop. Is it clear? We are checking for wrinkling of the forehead. In exophthalmos, there may be absence of wrinkling of the forehead because their eyes are bulging out. So they can conveniently see even if you go this far without wrinkling. So, but if you find wrinkling, it shows there is no exophthalmos. Is it clear? Is it clear? Yes. That sign is called the Geoffroy sign. When there is absence of wrinkling of the forehead, Geoffroy's sign. Is that clear?
Yes, sir.
So look at it. We stopped here. The next step, look at my finger, look at it. You now begin to come down. Look at my finger, follow it. You come down gradually. Follow my finger, you come down gradually. When you get to the midline, you drop it abruptly. And you see whether the patient upper lid can follow fast. Are you following? If the patient's upper lid is slow in following, you say the patient has upper lid lag. Lid lag. That sign is called von Graf sign. Von Graf sign. Is it clear? So, but that is what? Upper lid lag. Is it clear? The next eye sign to check for is ophthalmoplegia. Ophthalmoplegia means paralysis of the extraocular muscles. The paralysis that goiter patient, toxic goiter patient usually have is an inability to look upward and outward. Please, cameraman, be following me. An inability to what? Look upward and outward. That is what they normally have, because they have paralysis of the superior rectus and inferior oblique. So they are unable to look upward and outward. So how do you test for it? You come, you place your finger at the center, you ask the patient, please follow my finger. You move it to the side, then you move it upward here. You ask the patient, how many fingers can you see? You say 1. She's right, is it not so? So there is no ophthalmoplegia on that side. You come back to midline, you come through this way, You raise it up again. How many fingers can you see? There is no ophthalmoplegia again on this side. Exophthalmos patient can have ophthalmoplegia. When you do like that, you ask how many fingers you can see. They say 2 because they will be having double vision. Is it clear? Then after that, you do the last eye sign, which is Möbius sign. It tests for convergence. It's also called Möbius sign. How do you do it? You come to the midline, you ask patient focus on my finger, and then you gradually extend. You see the eyes of the patients are what? Converging. Then you say there is convergence. What we are looking out for is what? Loss of convergence, which you find in exophthalmos. So I quickly recap the eye signs. We have finished something, we are not in haste. I recap what? The eye signs. Number 1, from behind, you extend the neck and you look at an angle and see whether you can see the eyeball to check for what? Proptosis. Number 2, you stabilize the head, place your finger in front of the patient, inspect for conjunctival edema, inspect for staring gaze, inspect for upper lid retraction. Then you move your fingers up, asking patient to follow. You inspect for wrinkling of the forehead. You come slowly, you drop your finger abruptly and see whether the upper lid follows or there is a lag. Then you come back, you check for ophthalmoplegia. Is it also? Yes. Then you check for convergence. After that, you are done with eye signs. The next area to examine is the upper limb. Question examination is very long. So for the upper limb, please listen. Excuse me. For the upper limb, you take. Are you focusing well? Yes. Can't you raise it up? Cameraman, can you see?
Yes.
Are you with me? For the upper limb, you take the hands like this. First of all, you check for warmth and moistness on the patient's palm. Warmth and what? Moistness. Are you with me?
Yes, sir.
Then you extend the fingers out. You ask the patient to spread them out. If you have a paper, a plain sheet of paper, you put one on the right hand and another one on the left hand. If the fan is on, you request that it be switched off so that it will not create artificial what? Tremors. Then you don't put a single paper over the two because they can balance out. One paper here, one paper there. Then you ask patient shut your eyes. Then you now observe for tremors. After that, you bring the two fingers together. You observe for finger clubbing. Thyrotoxicosis can also cause finger clubbing. Then after that, you drop this hand. You focus on this. You check the radial pulse for rate and rhythm only. You check for what? Rate and rhythm only. Then you come to the arm. You check for blood pressure. After that, the last thing on the upper limb is to check for proximal myopathy of the upper limb. We check for what? Proximal myopathy of the upper limb. How do we do that? You apply resistance on the shoulder and you ask the patient to raise the hands up. If the patient can raise the hands up against resistance, it means the patient does not have proximal myopathy of the upper limb. Proximal myopathy means weakness of the proximal muscles. It happens in thyrotoxicosis. So raise your hands up against resistance. You see she can do it. There is no proximal myopathy of the upper limb. Another way to assess for proximal myopathy of the upper limb is to ask the patient to comb the hair. To comb your hair, you raise your hand up. Is it not so? Most patients that have it cannot do that. Once they start, their hand will fall down because there is a weakness. Or you give the patient a scarf and say the patient should tie her hair with a scarf. If she has proximal myopathy of the upper limb, she will not be able to do that. Then the last aspect of the goiter examination is in the lower limb. So you squat, pause.
No, don't worry, we'll cut this part.
Okay. You will sort everything.
Yeah.
You are a good cameraman. Okay. Are you with me? Are you with me?
Yes.
Please don't cut out my repetitions, so they are necessary.
Okay, sir.
So first, in the lower limb, you inspect the pretibial region. This is the pretibial region. You inspect, you look at it for pretibial myxedema. Pretibial myxedema is an edema that looks like lizard skin. It is usually non-pitting. So if you see it, you check whether it is pitting, and you will find it will be non-pitting. Is that clear? After inspecting for pretibial edema and checking whether it's pitting, the next thing to do in the lower limb is to check for ankle reflexes. Ankle reflexes, not knee jerk. Ankle reflexes. How do we do that? You take the forefoot of the patient like this. You take the forefoot of the patient like this. You cross it against the other limb. The forefoot crossed against the other leg. You take your patellar hammer and you strike the tendon Achilles with what? Patellar hammer. And you see the calf will be what? Contracting. If the patient has toxic goiter, the contraction will be exaggerated, what we call hyperreflexia. After doing this one, you drop this, you pick the other forefoot, you raise it, you cross it against the other leg, and you strike at the tendon Achilles, and you observe the contractions of the calf muscles. If there is toxic goiter, there will be hyperreflexia. Then the last thing for the lower limb, you also check for lower limb proximal myopathy. That is weakness of the proximal muscles at the pelvic region. Those muscles are the muscles that make you to stand. So you ask the patient to cross the hands on the chest and stand up without support. Once the patient can do that, you say there is no proximal myopathy of the lower limb. Sit down. Another way to do it is to first ask the patient to squat. Patient squat. And you now say patient should stand up from the squatting position without touching anything. If a patient has proximal myopathy of the lower limb, he cannot stand up. But if he can stand up without support, he does not have proximal myopathy of the lower limb. After that, examination of goiter is what? Complete. So you need to practice it to be able to do this. Tell the patient, thank you. Normal surface epithelium, there was a breach here. There is now an ulcer crater. This one you see is called the floor of the ulcer. This part where the ulcer forms a boundary with the surface epithelium of the skin, this part is called the margin. Now, between the floor and the margin here, this interval between is what is called the edge. So this is the edge. This one, this is the edge. Can you see the edge? Between what? The margin and the floor, you have what? The edge. And this is the surrounding skin. Surrounding skin. So you need to understand these basics to know how to examine an ulcer. Is it clear? So we will show you a simulated ulcer. To show you a simulated ulcer. Can you see the simulated ulcer? Why we are using the leg is because most ulcers are in the leg. Now, how do you examine ulcer? You start with inspection. You start with what? Inspection. Please concentrate. This is the last thing we are doing today. You start with what? Inspection. First, you compare the both lower limbs because it's a bilateral organ in the body. You should be seen to come. You look at this and you look at the other one to confirm that the ulcer is only in one lower limb. The first thing in inspection, you should be seen to compare both sides. After that, you now focus on the affected side. The first thing to inspect in the affected side is to note the site, the anatomic site of the ulcer by anatomy. If you look at this, our simulated ulcer, what will you call the site? The lateral malleolus of the left leg. Is it not so? That will be the anatomic site. So you should know how to do anatomic description. You look at the leg and you say proximal third, middle third, and what? Distal third. And those anatomic markings like lateral malleolus, medial malleolus, anterior surface, posterior surface, anterolateral, anteromedial, posterolateral, posteromedial. You should know how to use anatomic descriptions to define the site. The first thing you talk about the ulcer is what? The site. The second thing is the shape. Most ulcers are irregularly shaped. Most ulcers are what? Irregularly shaped. So you talk about site, you talk about shape. Then the next thing you talk about is the floor, like I showed you on the board. The floor is that surface of the ulcer you can see. Ulcer has its own language. That surface of the ulcer you can see is not called surface. For ulcer, we call it what? The floor. So you inspect the floor. Now, I will tell you, there are 4 possible things for you to see on the floor. Those are the 4 things you will be looking out for. 1, you can see granulation tissue. Granulation tissue looks reddish. Those are the things we try to show with this red painting on this ulcer. Granulation tissue looks what? Reddish. That's number one thing you can see on the floor. Number two, you can see slough. Slough look yellowish. If you look at this ulcer, in between the reddish part, you see some yellowish area. Can you see them?
Yes.
Some yellowish area. Those are the what? Slough. Then the third possible thing you can see on the floor of the ulcer is necrotic tissue. It will look dark. It can be greenish black, or it can be black or brownish black. Do you understand? So that is the third possibility. Here now we have some necrotic tissue. Can you see them? Can you see necrotic tissue on this ulcer? So those are the things you can possibly see. The fourth one is that you can see secretions on the floor of the ulcer. The secretion can be purulent, it can be serous, it can be blood. So those are the possible things you can see on the floor. So examination of ulcer is very easy. And when they say report your finding, very easy. You inspect the floor, you say there are granulation tissue, sloughs, and necrotic tissue on the floor of the ulcer. Finish. After the floor, are you with me? After the floor, you go to the edge. You go to what? The edge. I've shown you what the edge is. Because this is not a real ulcer, we cannot really make out an edge here. Do you understand?
Yes, sir.
But most edges of ulcers are slopy, like the one I showed you in the board. Most edges are what? Slopy. Black, quickly. Come to the board. This is a slopy edge. You see it? This is the slope. The slopy edge. The edges of most ulcers are what? Slopy. There are other types of edges. You can have an undermined edge, as in tuberculosis. You see the skin and the edge of the ulcer is undermined, as if it's eating under, like what all those miners do when they are digging a cave and they dig under it, undermined. Do you appreciate? So this sort of undermined edge you find in tuberculosis. Is it clear? Then another type of edge you can have is the one you say is punched out, as if you use a chisel to punch into the skin to create the ulcer. This punched out edge, you find it in syphilis. It's peculiar to syphilis. Is that clear? Now, the other type of edge you can find is everted. If this is the floor, sorry, if this is the skin surface, you find the edge is raised before going under to create the ulcer. Do you understand? This is what? A everted edge. You find it in cancers. So after reporting the floor, the next thing to report is what? The edge. And these possibilities are what you report. Either it is slopy, or it can be everted, or it can be undermined, or it can be what? Punched out. Those are the four possibilities. Is it clear? Yes. Then after that, you talk about the margin. Let's come and look at our simulated ulcer. After the edge, you look at the margin. The margin can be normal skin. The margin can be normal skin, or it can be hyperpigmented, or it can be hypopigmented. It can also be hyperemic. In this our simulated ulcer, what is the margin like? Hyperpigmented. You see the margin around, it's hyperpigmented. But also in the margin, you can have a mixed picture. It may not just be the same all round. Do you appreciate? Some parts can be hyperpigmented, some parts can be hypopigmented, some parts can be normal skin. So you report the margin based on what you see. If it is normal skin, you say so. If it is hyperpigmented, you say so. Then after the margin, you now inspect the surrounding skin. You inspect what? The surrounding skin. Again, the surrounding skin can be normal, or it can be hyperpigmented, or it can be hypopigmented. It can be hyperemic. Surrounding skin can be edematous. It can be exfoliating. You know what I mean by exfoliating? It will be peeling. Peeling, exfoliating. You can find the hair in the surrounding skin can be removing. Do you understand? The surrounding skin can be edematous and shiny, or there will be loss of hair, or you find some small ulcers around, or you find nodules around the surrounding skin. So whatever you find, you report. Is it clear? Is it clear?
Yes, sir.
Whatever you find on the surrounding skin, you report. After that, inspection is completed. You now go to palpation. So in palpation, you start with differential warmth. In what? Palpation, you start with what? Differential warmth. Are you with me?
Yes, sir.
In palpation, you start with what? Differential warmth. When you want to do differential warmth, you don't wear glove. When you want to do differential warmth, you don't what? Wear glove. If you wear glove, you cannot feel the differential warmth well. And so if it's husky, the examiners will mark you down for that because you don't have knowledge. Is it clear? So you come. How do we do differential warmth? You start from the normal. Is it not so? Then when you come to the abnormal, you will not put your hand over the ulcer. Are you following? You put it by the surrounding skin. Is it clear? And then you go back to normal. I do it again. The normal, the abnormal, but the surrounding skin, not over the ulcer. And then back to normal. Then after that, you wear your glove. Where is my glove? Okay. After that, you do what? You wear your glove. Don't worry. You now wear your glove. Then you now check for tenderness. To check for tenderness, you look at the face of the patient. You look at the face of the patient and you touch around the ulcer and see whether there is sign of tenderness. Do you see that? Many examiners don't like you touching the floor. Is that clear? So you check the tenderness by palpating the surrounding around. After that, the next thing to do on palpation is to measure the dimension of the ulcer. You take your tape, vertical, the widest vertical, you measure the widest vertical, you measure the widest horizontal. Is it clear? For postgraduate, they can allow you to use your fingers, and then you also carry your finger this way and assess how many fingers. But at your level, they like you using tape. It mustn't be tape, you can use a ruler. A ruler is easier, those small rulers. You just put it, you see the widest horizontal, you put it, you see the widest vertical. So after measuring the size, the next thing to do in the palpation is to palpate for the base of the ulcer. You palpate for the base of the ulcer. This is how you do it. You come around the ulcer. You check the consistency around the ulcer. That's what we call the base. Is it clear? Is it clear? You check the consistency all around the ulcer. The consistency, you check it. You report it as being indurated or not indurated. Is that clear? Indurated means it is hard. Not indurated means it is not hard. For ulcer, we don't talk about soft, firm, or hard. And we don't even call it consistency. We call it the base. And when you palpate the base, you say it is indurated or it is not indurated. You find induration mostly in cancers. Is that clear? Is that clear? Then after that, the next thing to do is to check for sensation. Give me cotton wool there. You check for sensation. You take cotton wool to check for sensation. How do you do it? You first of all come to a normal part of the patient. Madam, I'm going to touch you. Can you feel I'm touching you?
Yes.
Now you shut your eyes. If I touch you, you say yes. You start from that normal side.
Yes.
Do you understand? Immediately you have done that normal side, the patient knows what you are doing. You don't have time to waste. Do you understand? You go straight to around the ulcer and you touch around it, and you'll be listening whether the patient will say yes. If we say yes, that means sensation is what? Intact. After that, the next thing to do, you come to check for capillary refill. You press the nail of the toe, use the big toe, and then you release it and see if it turns reddish within seconds. Are you following? You check capillary refill. After that, you check for peripheral pulses. For the leg, the peripheral pulses we mostly check for are the dorsalis pedis and the posterior tibia. How do we check for dorsalis pedis? You come between the big toe and the second toe. Are you with me? You put your finger there. Your fingers you put between the big toe and the second toe. And then you scroll diagonally as if you are going toward the lateral malleolus. Then midway you stop and you feel for dorsalis pedis there. In surgery, we don't behave like native doctors. You don't just come, you just put your finger here once. Do you understand? You must define it systematically. You come between the big toe and the next toe, you run your finger like this midway, you locate the dorsalis pedis. Is it clear? Is it clear?
Yes, sir.
Then the next is to locate the posterior tibia. It's usually behind the medial malleolus. So first, can you see the medial malleolus? Are you getting it? Can you see the medial malleolus? So first you locate the medial malleolus, and then you slide your finger behind the medial malleolus, and you feel the posterior tibial artery. Is that clear? Behind the medial malleolus. Is that clear?
Yes, sir.
Then after that, the next thing to do in our ulcer examination, you check for movements of the joints close to that ulcer. So for this ulcer now, we will check movements in the ankle joint. You tell the patient dorsiflex and plantarflex. So you report it as normal movement around the ankle joint, or there is reduction of movement, limitation of movement, or you say there is no movement at all. Is it clear? Then you also ask the patient to move the toes up and down, and you also say whether there is normal movement, there is reduced movement, there is no movement at all. Is it clear?
Yes, sir.
The next thing in ulcer examination, you come and palpate for regional lymph nodes. First you check the popliteal group of lymph nodes, and then you check the inguinal group of lymph nodes. Then after that, you ask the patient to get up and to walk, and then you assess for the gaits. Is it clear?
Yes, sir.
After that, your ulcer examination is complete.